All right. I know you guys probably have had to do this like a zillion times, but will you all just tell me like, I don't know, who you are and where you're from? Like what kind of education you're getting right now or whatever. Things that I learned, um, I learned all of this really well after residency as I was sort of learning, as I was learning advocacy for single payer. I think that learning process exposed me to all these different things that I had to learn on my own. The awesome thing for you guys is you get to learn all of it in the context of this program, and from lots of people that know a lot about it. Most of this I had to figure out on my own, but that's fine. Um, Let's see. I'm still screen sharing. You can still see my screen, right? Okay, good. So I started thinking about the hospital sector when I was in residency. So I did med peds, so that's a combination internal medicine and pediatrics, 4-year residency, but you're allowed to sit for both the internal medicine and the pediatrics boards when you're done. I did that from 2005 to 2009 at UCLA, and one of the things I liked about that residency was we were in 5 different hospitals. We were in the fancy pants tertiary care hospital in Westwood, but we were also in a community affiliate in Santa Monica. We went to Cedars, which, if you pay any attention to where the stars give birth and get their medical care, Cedars is smack in Beverly Hills. It is rich. It is a community hospital as well, but it's really different than like the Santa Monica Community Hospital. We also worked at the West Los Angeles VA, and we worked at 2 different county medical centers as well, Olive View and Harbor. So the exposure that I got was really valuable, right? All of these different hospitals with totally different priorities, totally different patient populations served, you begin to see that care is not the same at all of these places, and it definitely makes you wonder why. And so I really got to thinking about that then when I was a resident, and then I moved to Chicago for fellowship, and so I did combined training in adult ICU and pediatric ICU. So that's MICU and PICU, and that was a long training process too. There was a lot of protected time for research. We won't talk about all the research that I did in host responses and sepsis and all of that stuff. That's a separate part of my life, but certainly a very valuable one, but not the focus of today. But the thing that was interesting about the University of Chicago is it sits on the south side of Chicago. It is a private academic medical center. It's a nonprofit. And it serves everybody in the community because there really aren't a lot of other hospitals on the south side, certainly not sort of tertiary care level hospitals. And so you get a mix of the super well insured people from the suburbs, coming out there for the latest and greatest in experimental medications. And then you get the community, which is, basically the 3 to 5 mile radius around the hospital. You call 911, you're going to get brought to the University of Chicago. And so it's a pretty complicated mix, ranging from some pretty poor neighborhoods, some neighborhoods that sort of suffered under neglect and redlining and a bunch of really complicated history in Chicago. But also, this is the neighborhood where Barack Obama used to hang out. So I used to live like a block away from him when he was in Hyde Park, which was always kind of interesting and cool. That was interesting to see how a single institution provides care for all of these different kinds of people as well. And now I'm at Kaiser Permanente in Hawaii. So this is a private integrated healthcare system. And lest you think, and you would not be wrong for thinking this. You're like, oh my gosh, he's gone to work for the enemy, if the enemy is private health insurance. So the Kaiser model actually works because we have a physician group that contracts exclusively with the insurance company. So the insurance company is not my boss. The physician group is, and then we negotiate with one insurance company rather than having to negotiate with a zillion different insurance companies. And there are a lot of pros and cons to this. Overall, I think it's amazing. So if we have time, I'll talk a little bit more about what it's like to work in this context. So that's where I am now. But before we dive into this discussion about hospitals, we have to talk about risk. And what is risk? Seems like sort of an obvious question. Obviously, fantastic board game, right? Or is maybe this movie with Tom Cruise back when he was young? This is like 1985. No, risk is, to be simple, it's the chance that something bad is going to happen. and you buy insurance to protect against risk, right? So if you have car insurance, you're paying a small amount called a premium to a company, Geico or Progressive or State Farm or whoever on a regular basis. And then when something bad happens, like you get into an accident, they will pay out, obviously minus your deductible or whatever. If you have life insurance, again, you pay a small amount to a company and the payout happens when you die. You have disability insurance. And let me just recommend, and I have no stake in this other than the fact that disability, like I think it's a good idea. When I was a resident, I was riding my bicycle down Santa Monica Boulevard because you can ride your bike all the time, and I got doored, which in effect means somebody opened their car door because they didn't see me. The end of my ulna got knocked into their car door, and it knocked the end of my ulna off. And that was painful, and I had to have surgery to put it back on. But in the process, I was like, holy cow, I can't potentially use my right arm or my right wrist. Like I'm an ICU doctor. Like if I can't like put central lines in and intubate people and do like, how am I going to be who I am? And this is when I discovered what disability insurance is, which is if you become disabled from whatever it is your primary scope of practice is, disability insurance basically provides income protection. And it doesn't prevent you from getting another job as a doctor, but presumably I wouldn't be able to work as an ICU doctor if I lost my arm or whatever. So I actually think that disability insurance is kind of a good idea because you never know when something is going to happen. And like you've invested all of this effort and money to becoming a doctor, and like for it to all just go down the drain just because somebody wasn't looking when they opened their car door. Like anyway, so but talk to your insurance professional. But anyway, the fundamental concept of insurance is this concept of a risk pool. And so risk pooling is the idea that everyone pools their resources together before anybody gets sick, right? So you got this nice population of people, they're all paying in a small amount. And then when somebody falls ill, the care is paid for from this pool of money. That is risk pooling. Everybody is sort of sharing in the risk, knowing that, we're not all going to get sick on the same day, but somebody probably will at some point, and then they're going to need resources to cover that. So, in these cases, who bears that risk? Well, ultimately, it's the insurance company. It's whoever the company is that you paid that money to. The insurance company is assuming your risk because they are the ones that are going to pay out if something bad happens, right? You lose your life, you become disabled, you get in a car accident, whatever. The insurance company is bearing that risk. So you might ask yourself, gosh, does this make any sense? Why would anybody want to become an insurance company? This seems like a weird thing to do, right? Well, let's just do a quick back of the envelope model. I am 49. Now, I can purchase a $250,000 life insurance policy for about $425 a year. At least that was what Google told me yesterday. Now, they make money if the risk of the event that happens to make them pay out over the specified time period, my death, is statistically less likely to happen compared to the money that they get in premiums, right? So they basically are hedging that I'm a pretty healthy guy. I just started taking a statin this year, but other than that, I don't take any medications, right? So my likelihood of dying is fairly low. And so they're hoping that I don't die, and therefore they just get to keep all that money that I pay to them in premiums, right? And of course, when they get that money, they can invest it in other things to make themselves more money, right? I'm giving them money. They can invest it in, I don't know, the stock market or real estate or wherever it is, crypto, like whatever they want to do with it, to try and make more money with the money that I'm giving them. Of course, recognizing that if I die, they're going to have to pay that out to my family. So, $250,000 policy, $425 a year. My risk of death, it turns out you can look up your risk of death, and just out of the gate, 1 in 200 per year, which I'm like, oh, that is not a non-zero chance of me dying. But then again, the only thing that's true for all of us is that we will all eventually die. So will the insurance company make money with me? Let's do this math. So 425 a year in premium, risk of death, 1 in 200. 200 people like me are enrolled, $85,000 in premiums, right? Because 200 times 425 is $85,000 in premiums. One of us is likely, statistically, to die this year. Wait a minute. That means they're going to lose money, right? Because 85,000 is less than the 250,000 that they're supposed to pay out. And so insurance companies play games in order to avoid this process, right? they try and find people that are even lower risk. You know, we're assuming that my risk of death is 1 in 200, but if you actually look at me and my genetics and my BMI and whatever all the other factors are that might make me die, my risk might actually be more like 1 in 1,000. I'd like to think it's like 1 in 100,000, right? Because, you know, I'm 10 foot tall and bulletproof. But, you know, you basically find people with lower risk, but make them pay the same amount, right? That's often called cherry picking. You're picking the best of them to enroll into your little risk pool. Now, a similar thing, or the opposite side of it, is called lemon dropping. We like our fruits here, right? This is avoiding high risk people. So, you know, I'm 49, but what if I also have hypertension? What if I've had a stroke? What if I've already had a heart attack? What if I have a BMI of 40 instead of a BMI of 31 or whatever my BMI is, right? What if I have diabetes already? All of those things make me statistically much more likely to die. So the insurance company is either going to jack my premiums up or they're just not going to insure me at all. They don't want me to play in their pool because I'm likely to die. They're likely to have to pay out. So they play all of these kinds of games with the numbers to basically optimize their risk pool and make it as less likely as possible for them to have to pay out. Now, you know, in my opinion, the best way to distribute risk is to have the biggest risk pool possible, right? Like that includes everybody that's high risk and all of the people that are really low risk. One gargantuan risk pool that includes people that are 10, whose risk of death is 1 in 8,000 per year, and 20, whose risk of death is 1 in 1,000 per year, right? Or 60, risk of death is 1 in 80 per year. The idea is that if we all are participating in one gargantuan risk pool, that risk is pooled across all of us, and so it's least likely to affect any of us as an individual. And also you have a bunch of low risk people in that pot. Like you got a bunch of kids in there, they're paying into it and very unlikely to die. So ultimately it's a kind of a win-win for everybody. So the idea here for health insurance, of course, is what if we included all 350 million Americans paying a menial amount to a single insurance company, which would, of course, we're arguing that should be the government. You know, this would eliminate this concept of risk adjustment. And I don't want to get into this too much, but risk adjustment is what happens when an insurance company says, well, I have a really high risk person, so, you know, I need additional revenue to cover them, for instance, because they're so high risk. It's playing games trying to modify people's you know, what their value is as a function of what their risk is. And again, risk adjustment doesn't really work, but it is the heart and soul of what insurance companies do to try and minimize their risk or maximize their revenue. So, you know, you're like, well, why is risk adjustment such a big deal? Well, here's the thing, right? Healthcare risk is totally unpredictable. Like you can't know that you're going to get cancer. Like things happen I can't know. I couldn't have predicted that I was going to get doored by that person that opened their door when I was on my bike. Now, you could say, well, Phil, you shouldn't have been riding a bicycle, but like, it's a good thing to do, right? No fossil fuels being used, right? It's good for my, you know, metabolism, like gets cars off the road, reduces pollution, like all these good things about it. And so, but that's coupled with the risk of something bad happening. And like bad stuff happens to people all the time. I have a 12-year-old girl down the hall who has a gargantuan brain tumor that is never going to get better. And 1 second.
Hey, so you're in a meeting.
Yeah, I am.
Just checking in.
Yeah.
If you're ready for that.
No, not right now. Yeah, thanks. You know, she has a gargantuan brain tumor, and like that's not her fault, right? Like, you know, and if she didn't have health insurance, they'd be on the hook for all the costs. Of course, the family would never be able to pay it because it's hundreds of thousands of dollars. And now she's stuck here. And unfortunately, the family isn't willing to sort of let her go. But that's an ethical dilemma that we'll talk about some other time. So, you know, it's unpredictable. And so having some people have insurance and other people not just makes the people that don't have insurance get crapped on by the system, right? Because they are at massive financial risk. But I think also it's important to acknowledge that healthcare risk itself is the result of structural inequities with both racist and classist origins, right? Designed to assure that the powerful stay powerful and the oppressed remain oppressed. I couldn't have learned this better than working on the south side of Chicago, where you have these kids that don't actually know that 1 mile away there's a lake, right? Because they can't even leave the neighborhood that they live in because it's not safe. And heaven forbid they actually play outside. Again, not safe, right? So can you imagine that their healthcare outcomes are potentially going to be worse? Of course they are, right? These kids aren't getting outside. They aren't they're stuck inside. They are in a constantly traumatizing world. Like all of these things contribute to them having higher rates of diabetes, right? Higher rates of obesity, higher rates of hypertension, higher risk of bad things. Like, and our system did that to them. I think that's important to acknowledge and important to keep in mind when we're talking about this. And I think a lot of healthcare risk isn't modifiable, right? People are like, well, why don't you just lose weight, right? It's not really like that, right? Losing weight had nothing to do with this little girl getting a brain tumor. Her having a brain tumor is just some, I don't know, some crazy genetic accident that happened or whatever. But like, it's not modifiable. And so you can't risk adjust it away. It's just going to happen. And so, of course, the argument we constantly make is that the most equitable and cost-effective solution is pooling risk at the population level. So I've now bored you with all this discussion of risk. You're like, I thought this was about hospitals. It is, but hospitals are inextricably linked to how they get paid. And that could be coming directly from the government. It could be via Medicare or Medicaid programs, could be from, private sources, could be from insurance companies. And the decisions that all of these funders make are related to risk. And so understanding that I think is really important for understanding why things happen in the hospital sector. Are you with me so far? Good. I think it's critical to understand this because then we can understand why hospitals behave the way they do. And the hospital landscape is like stupidly complex. So we're going to go through that in a little bit of detail. This is actually a two-part series because I can't cram it all into a single hour. It's just like a total information dump and it's too hard to process. So I think that the biggest problem that I would want you to take home with or one of the biggest problems is that hospitals are now forced to bear more of that risk. Instead of the insurance companies bearing the risk, they are shifting it to hospitals. And I'll talk about how they shift it to hospitals a little bit later on in the course of this. But I think, hospitals now become more financially responsible for what's happening with patients, and they can't afford it because they're not insurance companies. They have limited sources of where they get their funding. They have limited resources for what they can do with stuff. And it becomes untenable. So as far as I can tell, these are all the kinds of hospitals that we see out there, and we're going to go through them all one by one. Public versus private, safety net, critical access, academic, hospitals based on the type of care that they provide, and then profit status. And so we'll dive in with public versus private. So what's a public hospital? A public hospital is owned by the government. So it's publicly funded. And that means that, at least in the case of the VA hospital, which is a form of public hospital, the federal government actually owns the hospital. All of the docs at the VA are federal employees. Now, the VA exists basically to care for qualified people that have served in the military. And it's not even everybody that served in the military, but only people that have served for a certain amount of time or have sustained injuries in the context of their service to the country. But there are a lot of vets that get their care through the VA. And that is an example of a total publicly funded healthcare system. Then you'll have your local county or city hospital, and that's going to be owned by your local county or owned by your local city. And they care for everyone at all times, for all illnesses, regardless of ability to pay. But they're often they're sort of they're the safety net. They're the hospital of last resort. If you don't have insurance, they won't turn you away and they will take care of you. But inevitably, county hospitals are all the things that you can imagine they are, right? They can be busy, they can be overrun, they can be understaffed. And so when I was in Chicago, we had, Cook County Hospital, which became Stroger Hospital. Like it was such a famous hospital that the entire show ER was set in the Cook County Hospital. And it's all the things and more that they show on TV in terms of how complicated it is. But they serve everybody, and it is a public service. In fact, one of our leaders at PNHP, Claudia Fegan, She is the chief of the Cook County Health System. So she is the overlord over all of it, and is constantly thinking about how to take care of Cook County and Chicago's populations that don't have insurance, that can't get care elsewhere. And so that's all funded through county and city government coffers. Everything else is basically a private hospital. And they can be for profit or they can be nonprofit. And we'll talk about the implications of that later. Regardless of this, every hospital that exists has to see patients if it's an emergency. Now, they don't have to see patients if it's not an emergency. They can make choices about that. But in the context of an emergency, all hospitals are governed by this guy, EMTALA, which stands for, oh gosh, I don't have the abbreviation. It's like the Emergency Medicine Treatment and Labor Access. I don't know, something like that. So basically, EMTALA was passed in the 80s, and it said that every hospital must screen anyone who shows up in the ER to identify whatever medical condition they have, including active labor. And if they need treatment, the hospital is obliged to take care of them regardless of their ability to pay. Then they should be able to stabilize them. If that hospital can't do that, then they have to provide an appropriate transfer to another hospital. And then if you're a receiving hospital, you have to accept appropriate transfers from hospitals that lack the capacity to do that. And so basically a hospital must care for you if you show up sick to the ER. Again, if you're not, if this isn't an emergency, they're not obliged to care for you. But if you require acute care, then they are obligated to take care of you. But it doesn't have to be free. They have to take care of you, but they still have the right to send you a bill. And so that's kind of complicated, right? Because, if you can't pay, obviously you don't have a choice. If your appendix ruptures, you need your appendix taken out, right? Or you need that managed, but you're still going to get a monstrous bill for that if you don't have insurance. And this applies to all hospitals, whether it's a public hospital or a private hospital. And private hospitals, they are obliged to care for people too if they have an emergency department, even if they know they're not going to get paid for it. And what this in effect means is they have to eat that cost. But the reason that EMTALA came around in the 80s was because hospitals were dumping. And this started in Chicago. If you showed up at a hospital's ER and you were like, I don't have insurance, they'd be like, see ya. Or they would put you back in an ambulance and bring you to some other hospital without stabilizing you, without providing appropriate care. They would discharge you if you couldn't pay, even if you weren't ready to be discharged and you still required care. So this kind of patient dumping, this discrimination as a function of ability to pay, was well documented and published by one of PNHP's early founders, David Ansel, who is on the faculty at Rush University now. He's probably about retired by now, but when he was a young doc, he was like, this is crazy, this is wrong, and published a paper in New England Journal that ultimately resulted in legislation saying, all right, we have to cut this business out. This is crazy because it's clearly hurting people in a totally unjust way. So now I'm going to give you an example of how this works a little bit from my past experience at the University of Chicago. And so the University of Chicago, again, it was situated on the south side of Chicago. And we didn't have a trauma center. We were not equipped to provide trauma care, level 1 trauma care. And this became an issue because there was a teenager on the south side who got shot about a block and a half away from the University of Chicago. But the ambulance couldn't bring him to the University of Chicago because we were in a level 1 trauma center. So he went 10 miles away to Northwestern. On the way, he died. And the question, of course, that everybody raised, especially in the community, was, gosh, if the University of Chicago had been a trauma center, would he have lived, right? Would we have been able to get in there and manage his critical wounds and actually save his life? And it didn't help that he was a teenager who was part of a youth activist group that was basically advocating for the community anyway. Like, this is an amazing kid who got shot. And so I think that really mobilized people. And so, early on when I was in Chicago, I got involved with this advocacy for the university to become a trauma center. But this is why they didn't want to be one. And you can see on this infographic here that of the trauma patients, and this was now 11 years ago, only about 1 in 5 had private insurance. Many of them are self-pay, which means no insurance, right? So a sizable chunk didn't have insurance at all, or they had public insurance, or it wasn't clear what kind of payer they had. And so that meant that if you brought a trauma patient to the University of Chicago, you were very likely going to lose money on those patients. Because, like, in the heat of things, you spend a lot of money stabilizing them, getting into the operating room, and then all the downstream care that they need from that. Whereas if you looked at patients that normally went to the University of Chicago, there's a lot of privately insured patients in there, right? And not hardly anybody that doesn't have insurance. And so what this meant was the University of Chicago was like, hell no, we don't want trauma patients. We're going to lose money. They're going to be a total drain on our system. We're not going to be able, and the big academic center can stand up there and say, well, we're going to have to cut down other critical services and all this nonsense. But yes, I understand the need to keep the lights on and the need to sort of function in a financially stable sort of way, but not at the expense of turning your back on the community, right? And so what ultimately happened, this was, and this was EMTALA, right? Because if you have an ER that can take care of level 1 trauma patients, they're all going to go there. The University of Chicago actually in the 80s tried not to have an ER at all. They only wanted to take care of people affiliated with the university, which is so blatantly racist, it's not even funny, right? Because the communities around the University of Chicago are all majority Black communities. U of C was like, no, we're not going to have an ER. You just have to show your little University of Chicago card, and we're only going to serve that community. And so, the university has a history that is not so nice, right? So, it's ultimately, this was a financial thing that they didn't want to deal with. So we engaged in like a crap ton of advocacy, and I played a teeny role in that. It was really driven by a coalition of college students and then community high school students. And at the end of the day, in 2016, 2017, they agreed to build a level 1 trauma center, which was kind of amazing. But I bring all of this up as an example to show this is how hospitals are making decisions in the context of the healthcare system that we live. They're looking at payer mix, right? Because that's such an important part of how they keep the lights on. And yet looking at that is inherently unjust, especially if you don't look at what drives people's, economic inequities. So getting back to this public versus private thing, private hospitals can transfer patients to public hospitals once they're stabilized, but this almost never happens. So if I'm at the University of Chicago and somebody shows up, has a heart attack, and they don't have insurance, I would just take care of them, right? I wouldn't like stabilize them and then try and send them down to county hospital, because like county hospital is like exploding constantly. Like they don't have free beds to take in transfers. So the most effective, best thing to do for the patient is just take care of them. And then you discharge them and you say, hey, sorry, you can't follow up with us here at the University of Chicago. You're going to have to go down to the county hospital for all of your follow-up care, even though none of those people were involved in your acute heart attack care, right? Which is lame. But that's the system in which we live. So typically, yeah, private hospitals will care for those patients, then discharge to follow up with county or public hospitals. But even nonprofit hospitals, interestingly, are not obligated to accept a transfer for a high level of care for a patient without insurance. So when I was at the University of Chicago, if an outside hospital called, and the first thing that our transfer center would do would be like, do they have insurance? And if the transferring hospital was like, no, then, they would basically make up reasons to not accept those patients because they know that they're going to take a huge hit on it. They're never going to get paid for it. This is a de facto discrimination against people without insurance, right? Because the University of Chicago is a liver transplant center, for instance, and you need a new liver, and they're like, this guy's an acute liver failure. We think he might need a new liver. Can we transfer him there? And they'll find some reason to not accept him. And I think that's also, I don't like that. I don't think that's a good part of our healthcare system, right? It's only making things worse for people. And so, yes, we have EMTALA. I think that's good. I think that solved a lot of problems, but it has by no means fixed, all of the things that exist. And so now we're left with, this real two-tiered system where you have public hospitals and private hospitals and tremendous variation on who gets cared where. So if you have a public hospital, where is that money coming from that funds the public hospital? And how are they run? I mean, we could spend a lot of time talking about sources of revenue. Should it be, should they be run with global budgets? Should they be fee for service, charging for every patient they care for? Is it all just tax revenue that goes to fund the hospital? Or can the federal government just create more money? I did a video a couple of years ago about a thing called modern monetary theory, which is the notion that the government really could just print more money and solve a lot of the problems that we have. Now, we're not going to talk about that today either, but if you are interested, you can find that on the web. You know, in general, one of the things that I think is important to remember is that, especially with public hospitals, that funding is coming from the government, which sort of means that we, the public, should have some oversight over how it's spent. And that's I think one of the reasons that I believe that a public system is what we need, because right now we put it in the hands of private, whether it's private insurance companies, private corporations. We have no right to understand how they're spending that money or how they're making these choices that are absolutely, discriminatory. And so I feel like at least if we put things back into the public sector, we can actually begin to provide some oversight and assure that it's consistent with our values. So if you're comparing public hospitals to private hospitals, it turns out like we could spend a whole hour just talking about how much better VA care is. And you'd be like, but Phil, I've heard that the VA is terrible and everybody wants to get away from it. And the lines and the waits and the care sucks. It's actually not true. Like if you look at the objective data, the VA is awesome. Like if you have patients with new kidney failure that are at the VA, they're much more likely to be alive at 2 years compared to non-VA patients. And it's interesting because the VA simply does a better job of managing them. Why do they need less dialysis? Because they're more likely to end up getting transplants, right? They are actually, but the other problem with dialysis is a moneymaker. So we'll talk about that in a little bit, but these non-VA systems are like, well, shoot, we're putting them on dialysis because that's another source of revenue for us. But if you don't need dialysis, don't put somebody through it. So the VA does a better job of managing patients with acute kidney failure. Again, I could give you another 15 slides of all the ways that the VA is better, but rest assured, when the motive is simply to take care of patients the best way possible, the outcomes tend to be pretty good when you're not sitting there asking that question, how do we make the most money? So let's contrast this a little bit with a safety net hospital. Now, usually most public hospitals are considered safety net hospitals, but I think it's important to kind of define them separately. These are usually defined as hospitals with the highest inpatient stays covered by Medicaid or patients who are uninsured. So Medicaid is, of course, our program for patients that meet income requirements, right? Typically under the ACA, it's less than 138% of the federal poverty limit, then you qualify for Medicaid. And so, or if you just don't have insurance at all, these are the hospitals that care for the majority of their patients are those are considered safety net hospitals. And so they're more likely to be teaching hospitals. They're more likely to have a ton of inpatient beds. They're more likely to be in large metropolitan areas, and they're typically public hospitals. I will say our safety net hospital in Hawaii is actually not a public hospital. It's the Queen's Hospital, and it's funded by an enormous grant / foundation from like old Hawaiian history. So like Queen Liliuokalani had, created a foundation 150 years ago to take care of the people of Hawaii. And it's that foundation that partially funds our safety net hospital here in Hawaii, which I think is kind of interesting. In general, at safety net hospitals, they're much more likely to take care of kids. Why? Because kids are much more likely to be on Medicaid. They're much more likely to have maternal, sort of fetal neonatal care. Their patients are more likely to be admitted through the ER, which means they're having acute problems rather than being sort of scheduled for hospitalizations. And they're more likely to have behavioral health diagnoses. Safety net hospitals also qualify for what's called DSH payments, or disproportionate share hospital payments. This is basically the government transferring money to those hospitals extra because they know that they're taking care of a bunch of sick, uncompensated patients. So you probably know what the safety net hospital is in your area, but these tend to be like the big county hospitals that are taking care of everybody, turning nobody away. Unfortunately, they often have lower quality measures under pay for performance schemes. So what does that mean? So, you know, one of the things that people have dreamed up in the last 15 years is, hey, let's incentivize taking care of patients so that if you can get all of your patients to have hemoglobin A1Cs that are nice and low, showing that their diabetes is under control, we'll give you extra money. Okay, that sounds like nice on paper, but when you're taking care of communities of people that are underprivileged to begin with, right? That are poor, that don't have access to medications, that don't have access to healthy food, that don't have access to the ability to exercise, and therefore have higher rates of diabetes, that have ongoing stress. Like these are all things that lead to higher rates of diabetes. All of those patients are going to the safety net hospitals. So safety net hospitals suffer under these kinds of pay for performance schemes, and you actually exacerbate disparities. You think that you're like, hey, cool, we'll just incentivize doctors and they're going to make all their diabetic patients better. And actually it makes things worse. But here's separately from that, I'm really bothered by that because I didn't go into medicine. Like, I don't need you to incentivize providing good diabetes care. I'm going to do that because I'm a doctor, right? Like, I am trained to take care of people. Like, you don't need to do that. And if there are disparities, the problem isn't because doctors weren't taking care of patients well enough. It's all the other things, right? And so these kinds of solutions, these pay for performance schemes, are totally blind to the fact that like it's all the other social determinants of health that actually drive illness and not doctors just not doing a good job. Um, and again, for these safety net hospitals, these are the only options for uninsured or Medicaid patients because, like nobody accepts Medicaid and certainly nobody wants to see an uninsured patient. So you may be able to go there, but you may have to wait 6 months to see a rheumatologist, right? Or 8 months to get your cancer therapy. Oh, but wait, the tumor is going to grow very big. Like there are zillions of stories of how people who have just Medicaid or who are uninsured, depending on the county safety net hospital, die earlier for lack of appropriate treatment of whatever their disease is because they simply can't get access to it. These hospitals are more likely to serve populations more likely to be readmitted to the hospital or to have complex medical needs for all the things that we've talked about. So contrast safety net with a critical access hospital. So critical access hospitals, this was a concept created about almost 30 years ago in response to a bunch of rural hospital closures in the 80s and 90s. We saw a bunch of them just shutting down because they couldn't keep the lights on. And basically, it reduces financial vulnerability for those hospitals, also known as risk, by allowing cost-based reimbursement rather than pre-specified rates. And you're like, what are you talking about? So the notion of a pre-specified rate is, okay, you needed your appendix taken out. We're just going to reimburse you a set amount for that because this is the amount that we've decided that we'll reimburse you, $1,000, right? Instead, for critical access hospitals, they will literally be like, this is how much it cost us to take this patient's appendix out for the doctor, for the anesthesiologist, for the IV antibiotics, for the floor bed or the ICU bed or the OR time. And then the critical access hospital just gets reimbursed that amount of money rather than some predetermined rate, some set rate for the diagnosis. A lot of other stuff in healthcare, each diagnosis just carries a specific single rate. And then, if you can provide the care for less than that, you get to keep the money. And if you provide the care and it costs more than that, then you lose money. But critical access hospitals aren't subject to that. They just basically say, this is how much it costs to take care of our patients. Please reimburse us that. And then the government says, okay, here you go. And that really protects them from that financial vulnerability, especially in the context of like uninsured patients that you're not going to get money for at all anyway. A few specific things about critical access hospitals: they got to be small. They must be more than 35 miles from another hospital. The average annual length of stay must be pretty short, right? This isn't like a nursing home. This isn't a place where you're going for prolonged rehab. These are acute care facilities trying to provide acute care for patients in their communities. You have to have a functioning emergency room that's operating 24/7, and you have to have some staffing flexibility where you can flex up and flex down depending on what's going on. So these kinds of hospitals are often located in rural areas. I was in Illinois, and in Chicago, you feel like the sun rises and sets on Chicago, but there's a sizable chunk of Illinois that's just totally rural, and that may not have hospitals anywhere close by, and people have to go literally, dozens or hundreds of miles to get to the closest hospital. And because those hospitals do such small business, they can't hardly afford to keep the lights on, right? And so designating them as critical access hospitals provides them with some additional financial support to keep the lights on in those areas. We have this problem in Hawaii because, like, I'm on Oahu where Honolulu is, and that's great. We got all these other islands that don't have nearly enough doctors or hospitals to serve the populations that are there. All of those are, in effect, critical access hospitals. Now, next thing we're going to talk about is the so-called academic hospital. Now, some of you are at allopathic schools, some of you are at osteopathic schools, and some of you are at schools that may or may not have affiliated academic hospitals. So I would ask you, do you know what the relationship is between your med school and the hospital that it's affiliated with, if it's even affiliated with a hospital? Because many of them are not. And honestly, you probably don't. I didn't know anything about this stuff when I was in med school or residency. But sometimes the med school is separate from the university. So we had a couple of you at University of New Hampshire. So I don't know if New Hampshire's med school is separate from the greater university. At the University of Chicago, the med school had sort of a separate governance that was the University of Chicago Pritzker School of Medicine that was separate from the University of Chicago writ large. Or does the med school control the hospital? What's the relationship between them? When I was in med school, we had a university hospital affiliated with Case Western, but the med school didn't really control the hospital. So there was like a department of pediatrics in the hospital and a department of pediatrics at the university, and there was a lot of crossover, but they weren't the same. They had separate organizational structures, which seemed kind of dumb. Does your med school even have a hospital affiliation, or does it need to? There's clearly examples of successful medical schools that don't have designated hospital affiliations. They just simply create relationships with hospitals to let you do your third and fourth year clerkships and things like that there. And then, what's the relationship between med school and residency training? And where does all that money go? Like, all of the possibilities exist. Anything that you can think of has probably existed somewhere in this country. So for instance, some med schools, they don't have a hospital. So like I'm here in Hawaii, the Johnny Burns School of Medicine, the University of Hawaii School of Medicine, we don't have a hospital. So our Department of Medicine exists just to teach med students medicine. But in Chicago, the Department of Medicine captures clinical revenue from cancer patients, from cardiology patients. It captures research overhead from all the researchers that are doing research. It has a $250 million budget. It was huge. So it's a very different kind of Department of Medicine within that medical school compared to what I have here in Hawaii. If you have that affiliated hospital, you can grab that clinical revenue. You got a lot of money and a lot of resources to do stuff. And again, sometimes if you have research programs, that generates revenue via research overhead. And then, then there's the question of how do faculty get promoted and what does any of it even mean? Or do they have separate tracks or whatever? It's all incredibly complicated. And I had no idea until I started looking for a job as a faculty member. Some hospitals allow students to rotate, but they don't have an academic department. And I think it's also important to remember that money for training is tied to hospitals. So money for residency training comes from the Centers for Medicare Services and is distributed on a per resident basis. But the condition is that a hospital must accept Medicare and Medicaid patients in order to get that sweet money from the government. And in addition, when you take care of patients that are in these hospitals, the reimbursement you get from Medicare is actually increased for trainee care. So, the way the money flows in academic hospitals is incredibly complicated. And some of the more notable examples include, somebody's from Boston in here. So there's this thing called Partners. And Partners is a biomedical research organization, but it's also the teaching affiliate for Harvard. It's not the Harvard Med School. It's also not the university, but it's not the hospital. But it like governs the organization of all of these things, and it lets lots of places put Harvard in their name. Like Cambridge Hospital, right? Cambridge Hospital is a Harvard Partners affiliate. So they get to say that they're affiliated with Harvard. And yes, they're in Cambridge, but they technically weren't like the Harvard Hospital. But they get that sort of designation because they live under this massive umbrella of this humongous company called Partners. Or then you can look at Pittsburgh, right? University of Pittsburgh has the University of Pittsburgh Medical Center. UPMC is affiliated with the University of Pittsburgh, but it's not managed by them. And they have their own insurance division. And then they have a separate division for provider services. And UPMC oversees clinical activity, but the University of Pittsburgh handles academic priorities, including research, which has a ton of money. Like, it's crazy. So I think I say all of this to say we have academic hospitals in this country. How they function, how they run, where they get their money, it's incredibly variable. It's incredibly complicated. And I think that probably governs how they make decisions about whether or not they take care of patients, who they take care of, whether or not they have training programs, how they view themselves as servants of the community, since academic hospitals are generally nonprofit hospitals, so they're obliged to give back to the community. It's an incredibly crazy landscape. I'll wind things down here for today, just talking a little bit about the kinds of care that are provided at hospitals as the last thing we'll mention. And what do I mean by that? Well, a hospital is not required to see all patients or provide all services or even contract with all insurance companies. If you have an ER, you are required to see anybody that shows up in your ER, but you don't have to have an ER if you don't want to, right? So there are these network of hospitals in the country called Shriners. This is like a funded by the Shriners Foundation, and they provide musculoskeletal care for kids, regardless of ability to pay. They're like orthopedic wizards over there. So we have a Shriners here in Hawaii. You have them in various cities around the country, and they basically exist to provide any kind of musculoskeletal stuff. But they particularly tend to focus on kids that can't afford it or can't pay for it, and they don't charge anything for it. They don't have an ER. You can't show up there with your broken bone and be like, hey, fix my bone. You have to go somewhere else and get referred into Shriners. But and they don't provide all kinds of care. They provide all of the things you need around musculoskeletal care. But they do a really good service for a lot of people in this country. There's also the Cancer Treatment Centers of America. I think there's 4 or 5 sites in the country that have this. This is a for-profit hospital chain that just does cancer, but they don't accept Medicare or Medicaid. They only accept private insurance or paying out of pocket. And again, they can do that because they don't have an ER. So they can just be like, oh, you have Medicare? Sorry, we're not going to treat your lung cancer. But people go to them because they assume that a place that specializes in cancer is going to provide you with the best cancer care. And that seems like that should be the case, except maybe it's not when you actually look at the outcomes, because these guys exist because they see how profitable cancer care is. They cost the reimbursement on infusions, on chemo. These people have to keep coming back, so you keep being able to bill for them. You can make a lot of money taking care of people's cancer, and they're all gonna. A lot of them are eventually not gonna survive their cancer. So it's a different model for how to provide care for patients. A lot of hospitals used to have pediatric departments. Most of them are closing them down, especially for inpatient pediatrics, because it doesn't make any money. Kids, half to 2/3, depending on where you are in this country, of kids are covered by Medicaid. Medicaid is not a very good reimburser. The amount of money that gets reimbursed to the hospital for care of a Medicaid patient isn't very high compared to private insurance. So you don't make any money. In fact, you lose money. And so this sucks because, in Chicago, every hospital used to have a pediatrics department. And by the time I left in 2019, there were only 3 or 4 hospitals of the 25 in the area that still had active peds. And that makes it harder for all the other hospitals that are taking care of kids. But it also makes it hard for patients if you don't happen to live near a hospital that provides that kind of service. And of course, now we're seeing that hospitals are merging, right? They're joining these networks, and they may only have certain departments at certain locations. So when I was in Cleveland, I went to Case Western, and that's on the east side of the city. And it borders on some different neighborhoods, some that are pretty nice, some that are pretty poor. And the Cleveland Clinic, which was right next to where the Case Western was, at one point was like, all right, we're done doing obstetrics. Why? Because too many of the obstetrics patients were uninsured, were Medicaid patients, they were poor, and they would show up at the Cleveland Clinic because that was the closest hospital, and the hospital would lose money on their deliveries, and they'd be high-risk deliveries. And so they were like, all right, we're done. If you want to go to the Cleveland Clinic and you want to have a baby, we're going to send you to one of our suburbs, right? We're going to send you to the hospital out in Euclid, because of course, in the suburbs, the patient community around there is going to be a much more affluent one. And so, they simply decided not to offer obstetric services anymore. And I think that's lame, right? Like, you're a hospital in a neighborhood where people are having babies, right? And you're like, nope, sorry, our doors are closed to you because we lose money on you, right? Like, that seems to fly in the face of the need to be able to serve the community. But that's part of this notion that hospitals are building these networks. When I was in Chicago, the University of Chicago and Northwestern were competing for buying all of the suburban hospitals. Why do they want to buy up those hospitals? Because they can then, anytime somebody gets cancer in the suburbs, they've got a direct line into the big house in downtown, and that's a moneymaker. Anytime somebody has a heart attack, oh, they got to get transferred for their cardiac cath. They'll just come to the big house and make money for that, right? You need surgery, you need your, whatever, the things that reimburse well. If you have these connections to the places where everybody has insurance and nobody has a lot of medical problems, you can definitely make a lot more money or remain more financially solvent, as it were, in that context. And so what we're seeing now is consolidation in the hospital sectors in most areas where you don't really have just a freestanding hospital anymore. You have a hospital that's part of a hospital system. And that regionalization, maybe that's actually good, right? It in one sense, you can preserve high level expertise at a single site, um, and and that's good, right? Like right now, Chicago has 4 centers within a 10-mile radius that do congenital cardiac surgery. That's dumb, right? Like, if you want to do congenital cardiac surgery, we should have it all done in one place where we sort of pool all the expertise rather than having everybody trying to compete for that within that area. So, like, regionalization of care is a good thing from a planning standpoint, from a resource allocation standpoint. You can get some of these economies of scale where, like, the more people you put on cardiopulmonary bypass, also known as ECMO, the better you are at it. And so, like, let's do more of that at single places rather than having each hospital try and figure out how to do it. But of course, the cons are, services aren't delivered that meet the needs of a community. And again, like when Cleveland Clinic closed labor and delivery services at the main campus. And so this is a lot of what's driving mergers, is this need or this desire for regionalization and to improve your payer mix. And if you look at hospitals merging, we're finding that there are fewer and fewer independent hospitals and more system-owned hospitals. And this is data from 10 years ago. It's gotten far worse at this point. And in addition, hospitals are buying up these primary care practices. We're seeing the loss of solo private practices where people are just getting bought up by the local healthcare system, because one, that gives your patients access to that healthcare system, which seems like a good thing, maybe. But it also means that you're a salaried position. You suddenly have you have a boss rather than being your own boss, which you might have been in solo practice. I mean, honestly, in a way, this was accelerated by COVID. Here in Hawaii, we had so many solo practices. COVID hit, and they were like, I don't know how to get PPE. I don't know how to get N95s for my patients, my staff. So we're just going to close up, unless you were part of a bigger health system that could help you with distributing some of those resources. So, this has only been accelerated by the pandemic. And so, you might ask yourself, is all of this consolidation, all these murders, is that a bad thing? And we'll talk about that tomorrow. So that's all I've got for today. It's the top of the hour. If you think of questions, I guess I would say write them down. I'll try and reserve some time for tomorrow where we can have some more discussion about it. I have to jet right now because I have 2 other patients to go see. But thank you for your attention. And we'll see you all again.